So everyone, welcome to this webinar titled Open Your Eyes to 3D Imaging. It's going to be presented by Dr. Lea Al Matny. The goal of this webinar is to recognize when and how to implement three-dimensional imaging to approach cases in a comprehensive manner and help establish an accurate diagnosis before creating a reliable treatment plan. We will review different cases varying from implant planning, odontogenic and non-odontogenic lesions, root resorption, and fracture cases. Before we begin, let me introduce our speaker today. We have Dr. Lea Al Matny, who is a licensed oral and maxillofacial radiologist at See-Through Reports and a clinical education specialist at Carestream Dental. She attended the University of Texas Health in San Antonio, where she received both the certificate in oral and maxillofacial radiology and a master's in dental science. She's a reviewer for oral surgery, oral pathology, oral medicine, and oral radiology, and is actively involved in multiple committees at the American Association of Oral Maxillofacial Radiology. And without further ado, Dr. Al Matny.
Thank you, Tammy. Okay, let's see. Okay, you should be able to see my screen now. Okay, so thank you so much for joining us this evening. It's been a while since we had a webinar. Oops, I have to turn my webcam on. Okay. So usually, whenever we think of cone beam CT, we think of using it just for a specific procedure. So what I'm hoping to go through in the next 90 minutes is really to talk about the different usages of 3D beyond just treatment planning. So before I start, I know Tammy already introduced me, but I think there aren't much people who work with radiologists, so I wanted to tell you a bit about what I do every single day. I graduated from UT Health San Antonio, and like in residency, my goal was to make sure that I know how reports can help you in your practice, how cone beam can help you in your practice, and not just to learn the radiation physics and biology part of it. After graduation, I joined Carestream Dental, and one of my main responsibilities at Carestream is really to make sure your questions are being answered. So we would do this through one-on-one sessions, through webinars just like this one, CE, study clubs, and hands-on interpretation session, just like the video you're seeing here. So, and honestly, these are my favorites. So we would be a group of people going through the same cases together from morning until the afternoon, whole day just looking at CBCT scans. And by the end of the day, it's not just about recognizing different anatomical structures, but it's really about how to implement a system you can use every day in your practice, regardless of which scan, what type of scan you've taken. I also have my private practice in radiology, radiology services, which is called See-Through Reports. And I work with clinicians just like yourself who have a cone beam machine and need a second opinion on their scans. So between Carestream and See-Through, I feel like I've had more insight on the experience when it comes to new 3D users. And one of the things I've noticed is we usually tend to rely on cone beam or actually use cone beam when it's our last resort, when there's nothing else that can help us. Then let me see if there's something I can see on this scan, or when it's related to a treatment. So if I know this patient wants an implant placed, then I should take a CBCT scan. If I know I have to extract the third molars, then let me take a CBCT scan. But in fact, like cone beam provides us a comprehensive view, and I think should be part of our standardized diagnostic protocol. And This sentence doesn't really mean that we're going to use CBCT every time a patient walks in the office, but it means we should think of CBCT just like we think of pans or bite wings or periapicals as an option. So think of it as an option before taking a pan or a bite wing. You might take a scan and that would be enough. So in order for us to do this, we have to recognize the different parts where cone beam can help us. So know when to use CBCT, or maybe when not to use 2D. So that's number one, recognizing when we should take a scan. Two, understanding how to customize my scan. So what are the features that affect my image quality? And know that that image quality is not just because we want a pretty picture, but it's because it determines our diagnostic abilities. So the question you had before taking the scan will be easily answered once you know, once you see what you need to see. So if you have a good image quality, then you'll be able to answer that questions much more easily. So how to customize our scanning protocol. And three, after you've taken the scan, you've sent the patient home, you're in front of your monitor looking at that CBCT scan, what should you look for? What features should you always be aware of? So these are the three parts that I think are important to focus, and we're going to talk a bit about each one of them. But before we start, like if you have any question, please just jot it down in the question box and we'll get to it when we're done. Okay, so first part, when to use 3D imaging. And we're gonna talk about cases beyond implant planning or third molar extraction. I know you already know, not just that we need cone beam for that, but you know when to take it, what to look for. So we're gonna talk about cases besides that. Okay, so I got this first case from an endodontist I work very closely with in New Jersey. And this patient, this is the periapical x-ray from the general dentist, and this is the periapical x-ray from the endodontist. And the patient came in feeling pressure on her tooth. Whenever she puts her finger on her gum, it just feels sore. The tooth never really felt good, even after the root canal treatment was done. And with that, like she's talking about the premolar, she's talking about tooth number 13. And when we look at that tooth, we can see it's there's a root canal treatment. I can see there's PDL space widening, but I'm not sure I can see anything beyond that. Even if we like zoom in, take a closer look, if you see anything more, please just type it in the chat. But I don't think this answers the patient's symptoms. So our clinical findings do not correlate with our 2D findings. So this is when they decided to take a CBCT scan. The CBCT scan you're seeing in front of you is a small field of view, so a 5 by 5 centimeter scan of the upper left quadrant. And on the scan, you can see even before we start scrolling that we have an interruption of the cortex. So even before we touch that scan, we know something's up. We know something's there. So the first thing we're going to do, is to align our movement handles on that premolar. So we did that on axial view, now on coronal view, and then on sagittal view. And as we're aligning them, we have a much clearer look or view of that specific tooth. And what I did back here, let me just rewind for just a tiny bit. So we maximized one view because it's just easier to focus attention on that one tooth. And let me rewind, to focus attention on just one tooth without jumping from one view to another. So as we're scrolling, not only can we see where the interruption is, where the bone loss is, but we can see that the buccal cortex is thicker than the palatal one. And as I'm scrolling, you can see the origin. You can see that we have a perforation, a fracture at the cervical third level of the root. So it's not just trying to understand why the patient's feeling this way, but we know and we have an accurate diagnosis, and this gives you a clearer view on what to do next. So we can see this on coronal view as well as on axial view. Let me go back. So that's the line that we're looking for. Now you might look at this view and think, well, what about this area over here? Like we see a low density area around both canals, and it's not just specific to that. But I want you to focus that as I scroll, these are symmetrical to each other. So that's beam hardening from the obturation material, whereas the other line, let me go back to that line, will move along as I scroll from slide to slide. So that's the difference between recognizing an actual finding, a fracture, versus beam hardening around the root canal. So if we think about it, in this case, we actually were able to see the fracture line, but sometimes we have to rely on indirect findings on CBCT that tell us, hey, this can look like a fracture. So there's a paper published in Journal of Endo. It was published back in 2012, but I think it still holds value today with the different radiographic findings that can be suggestive of a vertical root fracture. So the 5 findings, radiographic findings that can be suggestive of a fracture are: 1, whenever you have loss of bone at mid-height of the root. So imagine having a tooth and you have bone, no bone, and then bone again. Exactly similar to the case we just looked at. So if I go back, bone, no bone, and bone again. So when you have a localized interruption of the cortex, it's not an endoperioral communication, it's loss of bone. 2, whenever the entire cortical plate is absent. And this is one example of that. This is another one. So you lose the whole cortex. So localized or angular bone loss, that's our second finding. 3, whenever you have a radiolucency exactly where the post terminates. So this is another suggestion that this might be a perforation. It's not just a periapical lesion or a lateral lesion forming around this tooth. 4, whenever you have a wide space between the cortex and the surface of the root. So imagine looking at this tooth over here. So we can see that we have PDL space widening, but it's generalized PDL space widening, and it's not minimal. So that space between the surface of the root and the cortical plate is also suggestive of a vertical root fracture. And the 5th one is when we directly see the fracture line itself, which is like the scan that we already looked at. And this is specific for endodontically treated teeth that have posts and crowns. And there's no rule as to say, oh, you can only see 1 of these findings, or you need 3 of these findings, or you need 1, 4, and 5 to actually say there's a fracture. We can't really decide that ahead of time, but in theory, any one of these findings can be suggestive of a fracture. You always need to correlate it with your clinical findings as well. Cone beam is never meant to replace your clinical evaluation. It's just meant to complement it. Okay. So in this case number 2, I also got this from an endodontist in Martha's Vineyard. And this patient had multiple evidence of microcracks on all of her posterior teeth. This was just one example of them. And the patient came in feeling discomfort every time she chews on number 3 and number 4. So this is the bite wing and periapical x-ray we have. The first thing I looked at was this root resorption on number 6. So before knowing the clinical symptoms, I actually thought that this was the reason why they took the scan, but it was just an incidental finding. If we look at this periapical x-ray, we might be able to see PDL space widening around number 4, but it's not something concrete. It's not something we can absolutely decide that this is fractured, let me go and extract the tooth. Whereas number 3, we can't really see any change around the PDL space. So with the scan we're going to look at, I have already aligned, I'm already aligned my movement handles. So just like we did in case number 1, aligned our movement handles on this tooth. I have already maximized this coronal view, and we're just going to scroll back and forth at this tooth to search for a fracture line. The rules that we talked about in the previous case do not really apply to this one because this is a virgin tooth. Whereas the other one, like, so in this case, like there's no post, there's no root canal treatment, there's no crown. So radiographic findings might be different around this tooth compared to the other one. So as I'm scrolling on this view, I want you to pay attention to start from the occlusal plane and try to find 2 lines that are really like a V shape. So let me point out one of them. So that's our first line. And as we're scrolling, you're going to see bits and pieces of it. It's an oblique line. It's not really a vertical fracture. That's why we have to keep scrolling to see it. So it starts from here, and there it goes, reaching around like 1 or 2 millimeters below the crest. Now there's another one that's much more subtle, right over here on the buccal. And the first one I saw was the palatal, second one I saw was the buccal. And as you're scrolling, we can see that how deep that fracture extends, and it will give you more insight on what you can do to treat this patient. So here's another example of the same case, not same case, like same scenario. So this tooth is the mandibular first molar, and as we're scrolling, we can see that that fracture extends from the occlusal plane, and it extends down below the crest, involving the pulpal floor, or involving the pulp chamber. And at this point, you can see that there's, let me go back and pause. Okay, that there is bone loss. So this is the distal of that tooth. There is localized bone loss, but it really gives us much more confidence when we see the actual fracture itself and not just rely on bone loss. So these root fractures, they are, their nickname, or they're called fatigue root fractures because they result from occlusal trauma. So heavy occlusal forces apply to the teeth. Mandibular first molars are the most common teeth that undergo these fractures from occlusal forces. And I think it's important to use CBCT scan, especially if you don't have any implants around that tooth, if the tooth itself is a virgin tooth, to help recognize any fracture that extends beyond the CEJ. Because a lot of times when patients come in feeling that pain, it would be either same day, next day, after having a certain incident. So I just bit on a popcorn kernel, or I just chewed an apple and came, or I got one where like he fell on the floor. So any type of fracture from occlusal trauma, if you're taking a scan the next day or the day after, you won't have time to actually see the bone loss form around it. There's not enough time in between the fracture and the CBCT scan. So we have to put in more effort and search for the fracture itself. Okay, so if we put fractures aside, This is a case that I got last year, and the first clinical symptom was that the patient had a sinus tract on the palatal surface of tooth number 11. Now, the teeth were vital. There was nothing clinically relevant to that sinus tract. Whereas on that panoramic reconstruction, we could see that there's a radiolucent or low density area in the anterior left maxilla. Now, it's easy to take a scan, look at number 11, and assume, well, this can be a lateral rarefying osteitis, so a lesion forming around the lateral aspect of the radicular surface versus something else. But if we look at other views, if you look at axial view, you can see that that lesion is not really focused around number 11. The epicenter is not number 11, but it just happens to scallop around it. So on this view, I think I can play the video. Okay, we can see that the lesion scallops between 11 and 12 and actually causing interruption. So that the interruption kind of explains that sinus tract. We have thinning and mild expansion of the palatal cortex. So if we look at different screenshots, we have to think beyond a lesion of endodontic origin, not just because of the interruption, but because of the scalloping that we saw in axial view and how the borders of that lesion are lobulated. So you don't have one small circular shaped lesion forming around the tooth, but the epicenter is actually the interradicular space between both teeth. And this actually turned out to be an OKC or a KOT, regardless, it depends on which terminology you're used to. But this is a very aggressive cyst or a neoplasm. And it's important to recognize what kind of cyst it is to actually biopsy and not just like intervene surgically and remove the cyst before knowing what it is, because this is a very, not just aggressive, but it has a very high recurrence rate. So within the first 5 years, after removing an OKC, there's a recurrence rate that's higher than 50%, higher than 60%, that it might recur, that it might happen again. So we need to monitor periodically, not just clinically, but also radiographically to make sure this does not happen. Whereas this is a case where it really looked very, very similar to OKC, but the difference is that tooth number 10 was not vital, and you can see that the lesion actually grows around the apex. So it's really a combination of your clinical findings and radiographic findings. How that lesion is behaving on CBCT scan is just as important as if the tooth is vital or not. Okay, case number 4. So I got this case a few years ago where this is the only pen we had, and Carestream will kill me if I don't say this pen was not taken by a Carestream machine. We can see that it's a poor quality pen, has poor positioning, but it's still diagnostic. We can still see what we need to see. Well, we're not going to go into the positioning errors now, but knowing what the patient is feeling. So sometimes she feels pain whenever she chews or lays down on her right side. If we look at this pen, and this patient, I think it came to the office over 3 times before she was referred to the endodontist, because there was simply nothing that indicates why she's feeling that pain. So they had ruled out any involvement of teeth. There's nothing on PA, nothing on a pen. If you look at this pen, we can see teeth, we can see bone, TMJ, we can see the sinuses, but there's nothing that jumps out at us. So on this pen, yes, we can see a mucus retention pseudocyst. we can see there's a large restoration on tooth number 31, but I can't really see anything more. Nothing that would indicate why the patient is feeling pain every time she lays down on one side or she chews on that specific side. And this is when the endodontist decided to take a CBCT scan. Now I'm just going to show you the scan of the area involved and not go through anything else, just for the sake of time. And you can see from the movement handles that we already aligned on the posterior right mandible. So this is also a 5 by 5 centimeter CBCT scan of the posterior right mandible. You just see it appearing as the left because the image is flipped, but this is the right side. So as I'm scrolling, you're going to see there's nothing wrong with teeth. PDL space is within normal. Lamina dura is intact. No root resorption, no teeth displacement. But what we can see is that the mandibular canal is widened. So let me rewind that video. And that point we see here is the mental foramen. And as we scroll, we can see a localized widening of that mandibular canal. Here's an example of where the widening is. So the widening is apical to number 30, and which kind of explains why every time she chews on that side, she feels pain. She lays over on that side, she also feels pain. So if you wanted to trace the mandibular canal, here's the mental foramen, and try to follow from that mental foramen all the way towards the distal. So you can see how the canal has a slender shape and intact cortices on the distal aspect, but apical to 30, there's a localized widening. And when we see this, we have to think of either a tumor of neural origin, of vascular origin, or malignancy. And this actually turned out to be a schwannoma, or a tumor of neural origin, which is really more benign and than having a malignancy. And the finding, like the how this lesion is growing, guides us into thinking that it's a schwannoma because it's very localized, it's ovoid in shape, and the rest of the canal is still intact. But it's really enough for us to recognize there's something wrong, to recognize there's a need to take a CBCT scan in this case. We don't even have to have a differential diagnosis or to know exactly what to do next. Because once you recognize there's something wrong, you can refer it out and get a second opinion. You can refer to the surgeon, but at least we have to try to find why the patient is feeling this way using a CBCT scan. So now if you look back at this pan, you might think, well, oh, okay, I see the widening in the posterior right mandible. I just didn't look enough the first time. But really, this can be a pronounced submandibular gland fossa. This could be the submandibular depression in the posterior mandible, which I'm sure you look at more pans than I do, you see these kinds of radiolucencies in the posterior mandible in every other pan. So here's an example of another panoramic radiograph, which has the same radiolucency, but this is a healthy patient with no schwannoma in their mouth. So not every radiolucency means that it's normal, and not every radiolucency means there's something abnormal. You can look in the anterior mandible and think, oh, there's another lesion there, but this is actually the ghost image of the cervical spine. So taking a CBCT scan, investigating further, making sure our questions are being answered is just as important as the clinical evaluation in this case. Okay. Now, if we go back to endo, here are some examples where you can see, okay, look at number 21. I'm pretty sure the tooth is broken. But it's easy to see, like, there's a crown, we have crater-shaped bone loss, the tooth is already treated. But once you take a CBCT scan, you'll see that this is not a fracture. This is not a radicular fracture or that the tooth is broken, but we have an untreated canal. We have an untreated lingual canal. You can actually like directly see the canal on axial view, and you can kind of trace it on coronal view on this side. This is another case, very similar, similar scenario where we have a crown, 4 treated canals, but that lesion is not healing. It stayed the same ever since we did the root canal treatment. But once you look at the CBCT scan, you can see why the lesion hasn't healed. So the original treatment involved the middle mesial instead of the mesial buccal. So we had 3 canals in the mesial root, and one of them was still untreated. So we can see that mesial buccal on axial and coronal view. So I'm just going to show you how we can align our movement handles just like we did in the previous scan. And we can see as we align them on each view, we can see more clearly. So we can see directly where we have that untreated canal, where should you access it from. Okay, so I wish I could have quizzed you on this case. Maybe next time we can even do, we can have a poll section in every other case. This way it would be more engaging, just like the way we used to do it a few years ago. Now, if we look at this scan, I'm just scrolling on axial view of the maxilla, and the clinical note that I got was, I know tooth number 7 is fractured, but how deep can that fracture extend? Now, if we look at tooth number 7, yes, we can see there's something abnormal on the palatal aspect, but this is not really a fracture. And part of the last part that we're going to talk about, which is the systematic interpretation, will really enforce us like looking at every tooth and not just the area of interest. So if we look at tooth number 7, we can see something, but we have to also look beyond number 7. So as we're scrolling, let me just jump to that video. Well, I'm just going to let it play. As we're scrolling, try to look at other teeth and see what else can we see. And we have a finding on number 15. Okay, here it is. Okay, so tooth number 15 has a very similar defect, just like the one that we see on number 7. And they are not fractured, but this is a type of root resorption. It's not internal resorption, and it's not a typical external resorption because you can see it acts very differently. Doesn't grow from the root canal space, and it doesn't form an obtuse angle on the surface of the root. So this is external cervical root resorption. You might know it as invasive cervical root resorption. And it really has its own specific characteristics. It's a very unique way of growing inside a tooth. It starts from one external portal of entry, which is hence the name, external, and that portal of entry is usually at the cervical level, so external cervical root resorption. And after that, the resorptive defect just spreads in the dentin vertically and circumferentially around the root canal space. So it tries its best not to invade the pulp chamber or the walls of the root canal, and it actually helps form a PRRS layer, a periradicular resistant sheath, to protect the pulp from that resorption. So in fact, what's happening, we're just there, it is just gaining more time inside that tooth. It will grow more, become more severe, and it's not before it becomes very severe that it invades that PRRS layer. So by that time, we would either like see it incidentally on a PA, just like the one we saw on case 1, or on CBCT, or the patient would come in feeling some kind of discomfort, or you might probe, and which is like, I think what happened here, because like when they probed on tooth number 7, they could see that there's a fracture, but in fact there wasn't. So it keeps on spreading. And for the longest time, we've used HEDER-SA's classification to determine what extent this resorption is and whether should we treat it or not. But like there's been multiple researches, and especially using CBCT, that talk about a three-dimensional approach to that root resorption. And we're talking about it more other than other findings, just because it's very common. It's silent, patients are asymptomatic, and it's aggressive. So between these three reasons, I think we should keep a closer eye on it, especially if you already take scans. I actually have a specific scroll, a dedicated scroll for root resorption at the end of each case, just to make sure there's nothing there. So these are different examples of how external cervical root resorption can look like. You can see that they vary in appearance, they vary in shape, but they all have the same specific concept. One portal of entry spreading inside the dentin, could be localized to one side, just like we're seeing over here, or it could spread around the root canal space, not inside it. It can eventually invade the root canal space, but it has to get to a more severe level. So the latest classification that is actually being replaced from HEDER-SA was the classification released in 2018. So we can see that it is now based on height, on circumferential spread, and the proximity to the root canal space. I just added this last portion, which is the location of the portal of entry, because I think it's just as important when it comes to your decision to treat. So yes, height, circumferential spread, how many intact radicular walls do you have left? Is it invading the root canal space or not? Are all very important. But if you can look at the name, like the article's name is three-dimensional descriptive classification. So this is the first part of classifying this type of root resorption, but it doesn't correlate with treatment. So when we did our study on external cervical root resorption, we saw that every one of our readers, so they were board certified endodontists, they could see that they could determine whether they're going to treat it or not, really in the beginning, based off not just the extent, but also the location of that portal of entry, if it's easy to access or not, if there are multiple portal of entries or not. So this is just as important as the height and circumferential spread. Okay, this is another example of external cervical root resorption. And oops, let me play the video. You can see in this case that we have multiple resorptive defects in that patient's mouth. So I wanted to show you that case just as a reminder. Every time you see one root resorption, make sure you do like a quick stroll to look at the rest of the scan and rule out presence of any other resorption as well. Okay, so so far between fractures, resorption, pathology, even just like simple endodontic cases like a missed canal or a perforation, you can see that cone beam is important for our diagnosis. But it's one thing to just take my word for it or the cases that I've shown, and it's another thing to look at numbers and percentages from the literature to see if it holds value or not. And this is just like another quick case showing the simplest, most underutilized applications for CBCT are really important when it comes to your treatment planning. So this patient had, they had normal, all the teeth shown were normal to cold, to percussion, to palpation. nothing wrong. But once you see a CBCT scan of this exact patient, you can see that we have a periapical lesion forming around the roots of number 15. And I'm going to go back to this view to see, oh, you also have an interrupted sinus floor with localized mucosal thickening. Now, this does not mean seeing a periapical lesion forming that you're gonna directly treat that tooth. You might treat it today, you might treat it in 6 months, you might treat it when the patient actually feels pain. The decision to treat or not, in my opinion, is irrelevant on our diagnosis. It's just as important to understand what we have in patient's mouth before placing a crown. So this is one of the, I think, underutilized applications, and the numbers also show that. So you can see there are 2 papers. One was published in Journal of Endo, another one is International Journal of Endodontics, and they both try to determine the number of periapical lesions forming on 2D versus on 3D. And the 2 numbers we got were 34%, and the first one was 28%. So there were 28% or 34% undetected periapical lesions on 2D imaging compared to when we looked at the same cases on 3D. So I think like 1/3, 30% is not a negligible number for periapical lesions, but it also doesn't mean you have to go and treat everyone you see. The third paper that talked about periapical lesions was an incidental paper that focused on incidental findings on CBCT scan. And periapical lesions were the 3rd most common incidental findings. So I think it's just as important to focus on, to recognize the importance of cone beam when it comes to treatment. And this is a very quick snapshot of what you probably see the whole time. So you take a PA, you see a radiolucency, it's easy to assume that, okay, this can be a perforation, this can be a fracture, this can be an untreated canal, it can be anything you want. But the fact that we're using the word can be or might be or I'm not sure, this is where you have to pause, investigate more, and not rely on that possibility. So to use every tool you have to get an accurate diagnosis. And in our study, when we were looking at external cervical root resorption, some of the cases were determined as to have a good prognosis on hearsay, and then when they actually took the scan, they decided this cannot be treated because the root resorption exceeded 28% of that root volume. Saying this is another paper when it comes to deciding to treat or a surgical approach for impacted 3rd molars or impacted teeth. So you can see that their decision to treat was changed in over 58% after they looked at cone beam. It didn't mean they weren't going to treat, but it could have meant their approach or how they're going to treat it. So at this point, we could be thinking, okay, we know cone beam is important, we know we can use it, but how does this? Why aren't we using it more? How is this technology not being utilized as much? And the first thought would be radiation risk. We're probably exposing the patient to a very high effective dose, and that's why we're not relying on cone beam as much. But if you look at how the technology has progressed in the past decade, the effective dose that comes with exposing patient to a CBCT scan is comparable to the effective dose that we get from a 2D image. It doesn't mean we have to replace every 2D image or full mouth series with a CBCT scan, but it does mean it's time for us to start considering it more. We're not exposing the patient to more radiation exposure if we had taken a scan instead of a full mouth series. So in a full mouth series, the effective dose is 177, whereas if we take a medium field of view, 12 by 10 of the mandible, maxilla, you'll get part of the sinuses and both rami. The effective dose is 120 at standard resolution. So the effective dose on CBCT will vary. It will vary depending on the resolution you're picking, the field of view, the patient size. There's a lot of factors when it comes to the effective dose on CBCT. But like this variation or this change in effective dose will be comparable to a 2D image. So if you see a 120 number versus 177, it does not mean that every scan you take will be less than a full mouth series or less than a pan. In fact, like if we compare with a panoramic radiograph, a pan is much less than CBCT. So it's 56 microsieverts compared to 120. But we also have to think back, by the time that I think about taking a CBCT scan, it means I need it either for my diagnosis or for my treatment planning. Will a pan give me the same information, or am I gaining more from this CBCT scan? And like other times we take a pan, we take multiple PAs with different angulation. You might even have one with an error, one with a cone cut, or one taken on the opposite side. We don't consider the radiation exposure that comes with 2D imaging, but we do think 10 times before we take a scan. So I think they are comparable to each other, where we should think of CBCT before automatically going back to our habit, taking a 2D pan, then full mouth series, and then taking a scan when we need it. So if we had taken this same exact scan as low dose, the effective dose would be 22 microsieverts. Another example, a 5 by 5 scan of the anterior maxilla, effective dose is 5 microsieverts. If I take the same exact scan and I place it in the posterior mandible, this makes it 10.4 microsieverts. So these numbers will vary, and if you want a copy of the effective dose, you can reach out. You can actually like type it in the notes at the end of the webinar, or reach out to your local sales rep, and they can give you a chart that has the different effective dose or radiation exposure of your specific machine. So if we go back and read the guidelines that we have, this was published in also 2012. And this statement was from the ADA Council of Scientific Affairs. And they basically say that it's your decision to either use cone beam as an adjunct or to replace 2D with CBCT, whether it's for diagnosis, for treatment plan, or to monitor, to follow up. So we really need to use the method, the imaging method that answers the question you have. For the longest time, we've been thinking of the ALARA principle, as low as reasonably achievable, but this has slowly shifted to as low as diagnostically acceptable. So the only thing that we care about is which question do you have, the purpose of the study, why you took the scan, and will the imaging technique that you picked address this purpose, address this question. So if we consider using a LARA principle, or as low as reasonably achievable, you can take 10 low dose pans from until tomorrow, but will that answer the question you have? So consider case-by-case basis, diagnostically acceptable instead of as low as reasonably possible. So 2 scans, different locations, different resolution. have a different question. They are answering a different question. So in the posterior mandible of that implant, we're just making sure that that implant is placed in the proper angulation, that it's properly integrated, and this just takes 10.4 microsieverts. So if we had taken a PA, we would have the same effective dose. If you're suspecting the patient's in pain, feeling some sort of discomfort, it's okay to take a low dose small CBCT scan to have a more in-depth look of that implant. Just like if you're searching for a fracture on a tooth, analytic treated tooth, it's okay to take a high resolution CBCT scan. If we are searching for a fracture but we take a low resolution, we're not really addressing the clinical question we asked. Another example, PA versus low dose CBCT. And again, the 5.5 versus 10.4 is just because it's a different region. Okay, so we first talked about how can we benefit from CBCT with different scenarios, how often can we use it. But once we decide to use CBCT scan, we need to customize our scanning protocol or our imaging protocol. So the 4 most common settings that we can use cone beam with would be field of view, whether you sit the patient or not, what type of resolution you're picking, or if you apply metal artifact reduction. I'm just going to show you a few examples of how our acquisition process can affect our image quality, because we usually have miscommunication between what we're thinking, what we want to see when we decide we need to take a scan, and then what our team is doing behind the machine. If you're taking your own scans, that's perfect. But if you have someone taking your scans for you, then we need to make sure that every term we use, they are also understanding and translating that into the settings found on the machine. So if you're searching for a fracture and you need a more in-depth look of that tooth, then your team should know we should take a small field of view scan, high resolution, apply a metal artifact reduction, just in case there are crowns or posts or implants around that tooth. So this way we can guarantee that we are going to see anything we can see. And versus if we wanted to evaluate relationship of third molars to the mandibular canal, then we would take a larger field of view, so a 12 by 10 scan, standard resolution, sometimes even low resolution. You don't need that much to see the mandibular canal and the tooth. And just to remove any noise, let's apply the advanced noise reduction. So for larger fields of view, it's okay to apply advanced noise reduction. For smaller fields of view, endo, you might want to use the MAR filter, the metal artifact reduction. So these different fields of view or parameters that you're using before you take a scan are 100% related to the question you're trying to answer. We don't want to take 4 small scans whenever you want to evaluate proximity of the nerve to the APCs. You're just, in that specific case, you would be subjecting patients to much more radiation exposure. You have 4 files you need to save instead of just 1. So each one would take up space on your server, and you're not really doing the patient any good. You're spending time looking at 4 scans, opening each one of them instead of just taking one and doing everything on one same case. So an example of metal artifact reduction, this is a small field of view scan, posterior right maxilla, and you can see we have crowns, implant, posts, and in this case, it's very normal to see beam hardening. So to see a dark area between the post and the implant. But as we play the video, once we apply metal artifact reduction, we can now actually see if there's bone or not. If we have bone loss, where is that bone loss localized? Is it only around the post, or does it also involve the implant? And you can see as we go back and forth between FDK and MAR, it just makes our diagnosis much more clearer, and it gives us more confidence. So you never want a filter that is always applied to your scan. We don't really want to change what the original data looks like. We need something to enhance it, to improve it, but I always want to make sure that that improvement is doing its job, it's doing what it should do and not doing anything worse to it. So if there's a small thin fracture line, there is a possibility that that filter will hide it. So, and this is one of the features that I love most about this software, because it's patented by Carestream. So go back and forth and see what the actual scan looks like, and then what the scan with the MAR filter looks like. Another example is using CBCT for airway evaluation. So these are two different, this is the same patient. It's actually an orthodontist in San Antonio. His name is Dr. Tito Norris, who took the scans on himself. So you can see that the airway cross-sectional diameter, the oropharyngeal cross-sectional diameter changes depending on the position of the patient. So if you have a patient with their shoulders back, straight neck, Frankfurt horizontal plane, then his oropharyngeal cross-sectional diameter was 394 millimeters squared, compared to having a patient leaning down, their chin is down, their neck is back, with their body forward, just slumping inside the machine. It would make us think that the patient has a risk for obstructive sleep apnea. So the measurement came down to 74 millimeters squared. So that's just to tell you that, like, how you position the patient inside the machine affects not just image quality as in how pretty the image is, but your decision to diagnose and to treat. So in this example, if you want to evaluate a patient, evaluate the airway of a patient, it's best to make sure that the neck is straight, the shoulders are straight, the patient's tongue is touching the roof of the mouth, and you can sit them down or have them stand up. I think if they're seated, they are much more stable. I would prefer sitting. If you have the 9600, sit down your patients regardless why you're taking that scan, especially if a patient has tremor. And once you had taken the scan on the first day, when they come back 6 months from now, 5 years from now, and you want to evaluate the airway again, the machine will tell you the exact same position, which how you took the scan the first time on this specific patient. So it helps us gain a bit of consistency. I don't think we need to go through how to measure the airway, so I'm just going to skip that. If somebody has a question on it, then we can go back to it. So another feature that is important for us to determine would be image resolution. So the quality of this, difference in gray density that you're looking at, the sharpness of the scan really depends on not just the voxel size you're using, but the power of, like, the KVP that you're applying with that machine. So taking a scan at 90 versus at 120 kV, which milliamperes you're using, they're usually at default settings, which is good. But the decision to take between 90 and 120 is something we have to manually decide. And you can see, like, the sharpness of an image and like how that root is growing around the mandibular canal. Another one was the field of view. So this patient came in with generalized pain on her left side and couldn't really tell which tooth is the culprit. So when the clinician took the CBCT scan, they could see that that pain is most probably coming from tooth number 18, so where there's a deep caries, but at the same time, you can see how close the roots are to the mandibular canal. Okay, so third part, how to interpret CBCT scans. So by now we know when to take a scan. We customized our scan, image resolution, field of view, and you would be looking at any kind of scan you have, whether it's small, medium, or large field of view. We can approach it the same exact way. So how should I approach every scan I have to be consistent and at the same time efficient? Okay. So the first thing we need to recognize when it comes to interpreting CBCT scans is that we are naturally biased. As human beings, we're biased, we have cognitive bias, and we're affected by the information provided to us by the patient. So every time a patient comes in saying, I am sure that the tooth that's causing me pain is number 11. 1000% sure it's 11. The first thing you're going to do when you open the patient's mouth or when you look in the chart or when you look at the CBCT scan is take a look and see what's up with number 11. You might look at everything else, especially if you didn't see something wrong on number 11, but if you did, if the pain is specific to one tooth, then that's all we're going to focus on. So in order for us to have a systematic interpretation approach, we need to try to set aside our bias. And I think there are two important books that guide us on how to do that and when we can do that. One of them with Daniel Kahneman. Kahneman talks about our two system, how our mind works when it comes to every daily activity we're performing. So if you are placing a composite, placing an implant versus jogging versus driving, this is how our brain functions. And James Clear talks about how we can change our habit. So first, understanding how we function as human beings, and two, how can I unlearn what I was already taught in dental school on how to look at 2D images, and how can I create a new system specific for 3D? Because right now what we're doing is applying every information we have from 2D to 3D. This is why most of the hands-on that we get, what I see is like we manipulate the scan, we control it, and we get to one specific area, and then we remove our hands from the mouse. So we stop scrolling and we only focus on what we're seeing now. Versus on 3D, we have to act very differently. We have to change each view, keep scrolling back and forth because it just tells us more about how this lesion is behaving. So if we start with our bias, the two systems, we know that we have system 1 and system 2. System 1, we're probably using 95% of the day. So every time you are talking on the phone, you are talking with a patient, you're driving your car back home from your office, you're using system 1. Yes, it is more error prone, but we have a very lazy mind where we can't use system 2 every time we need to do something, to do an act. So we really tend to keep system 2 for whenever we have whenever you're nervous. Like if you think back to the first time you drove a car, you had dedicated so much energy on that act. You were nervous where to put your hands, when to turn left, when to have your foot on the brakes. So, I mean, I was even nervous if I could open the window or not. I could not multifunction. Versus compared to when you were driving this morning, very different behavior. So I don't want us to use system 2 every time we look at a CBCT scan. It's just not efficient. But at the same time, we need to learn a new system 1. Right now, we're using our current system 1 is the one that we know when it comes to panoramic radiographs, periapicals, and then we're applying whatever knowledge we have there onto cone beam. So in order for us to build a new system, we need to create consistency. We need to make very small changes. They're so small that you can't say no. And like the example that I read in this book that I related to the most was like going to the gym. So if I decide that I wanted to start working out again, what I used to do was like I used to go to the gym once a week on Saturday, stay there for 4 hours. And that is just not something productive. This is not creating a system. This is waking up the next day and being sore. But what I should do is go to the gym 15 minutes today, 20 minutes tomorrow, even like drive to the gym the first day and not even go in. So make very small changes where you're just telling yourself, well, I'm just driving there, or I'm just walking in and saying hi to the trainer. I'm just walking in and doing 15 minutes. So you're not just applying this big, overwhelming change on yourself and not knowing what to expect, and at the same time, not having time to practice. So when it comes to cone beam, these small changes really relate to with where, like the location where you're looking at your CBCT scans. Is it in your office? Are you fluctuating every time? Because to create consistency, to create a system, we need consistency. So look at the scans every time in the exact same location, same PC. We don't want to look at a scan the first day from your living room when you're remoting into your office, the second day in your practice office, third day at the acquisition PC. You're just confusing your mind more. And this doesn't mean that this is the way it has to be forever, but it means in the beginning, before you create a system, these are the things we need to do. So for us to create a habit really has nothing to do with how many years you've owned the cone beam, how many scans you've looked at, how many patients you've sent out to look at the CBCT scan, but it's about the number of times that you've performed the same act consistently. So every time I sit in front of this monitor, I click on the Carestream software, I open a CBCT scan, my mind knows that my next thing is to create a panoramic reconstruction, then to trace the mandibular canal, then to go to MPR, or if you're still using the older software, to go to oblique slicing and to properly evaluate every structure there. So the system starts with your physical location to which buttons you press on the software. And that software is, it's not just robust, it has a lot of features you can use. I really would prefer that you don't learn all the features the first day because it is overwhelming. So in the beginning, we need to learn the basics. Learn, master the basics, because you don't need more than the basics for diagnosis, and then start to add new applications every week or every month or every 6 months, depending on how much you're using that CBCT scan. So in our system, when you open the software, and like one more thing that I didn't mention was which software you're using. So it can be easy to think and it's not about like having a CBCT machine in your office, but it's more about, think about every time you get a CBCT scan on a thumb drive or a CD drive. So like I dread the times that I get a USB or CD, because one, it takes forever to load, and I'm not even sure what virus, if there's a virus on that thumb drive or CD. And by the time you figured out how to open the CD, which folder is the scan located in, how to use the software that's attached to the CD, then that energy is wasted. So again, we have a very lazy brain. You will probably spend less than half the time dedicated on that scan compared to if you already have the software downloaded. So whether you have a machine in your office or not, if you are looking at CBCT scans, receiving CBCT scans, make sure you're using the same exact software. This way we learn a software once and then go from there. The energy we're spending is just on the scan, just on this specific patient, nothing to do with which button should I click, because this should be part of our system. If you already have a software you rely on, that's perfect. If you don't, I would recommend the Carestream software because one, it's free, and two, it's very robust. It will have everything you need. So it will open most scans that are saved as a DICOM, but keep in mind, as a free imaging software, there might be some scans where it cannot open if it's taken by another CBCT machine. A lot of this has to do with not just the proprietary DICOM they have, but also how they exported that scan, and which method did they export the scan and send it to you. But if you download the software, or if most of your referrers are Carestream users, then you can just get the CBCT scan and open it with the software that you already have. You would learn one software instead of learning 10. Okay, so every time we open a software, we want to create our system, we really have two goals in mind. Oops. We want to look at all images first. So we want to rule out any evidence of pathology in that specific scan. And then we want to address the area of interest. It can be very tempting to open a CBCT scan and just focus on the area of interest and then say to yourself, well, I'll skim through the scan when I'm done with my implant planning or when I'm done with tracing the canal. But because we are biased, in a busy office, knowing that you have limited time, you'll probably not spend enough time scrolling through that scan. So when we're addressing goal number one, what we're doing is just asking ourselves, what else do I see? Yes, I see that big lesion on tooth number 30. What else is there in this scan? So constantly talk to yourself and ask, is there something else on any other teeth, the sinuses, in the bone? So ask yourself questions that would probe you to investigate further. And we're doing this on this view. So if you were using the older version of the software, which is, and I think you can correct me if I'm wrong, but I want to say it's 3.10.35. That's the older version. Then this is what you see under oblique slicing. And the newer version, which is 3.10.38, you would see this under MPR, multiplanar reconstruction. If you don't know what I'm talking about, older version, newer version, there's a nice video that goes through it. If you contact your sales rep or even reach out to us after the webinar is done, then we can make sure you have it. So this is what we see on axial, we see axial, coronal, sagittal view. We also have the 3D rendering, which we will not use for diagnosis. We're going to use these 3 views and maybe use 3D rendering to try to recognize where we're at. So it can be overwhelming to see 3 views at the same time, not knowing where do I start from. And it's tempting to scroll on one view, see a finding, manipulate our movement handles, and go down the rabbit hole just looking at one tooth for the next 15 minutes. And there's a sense of satisfaction when we find something on CBCT scan, between us being happy that we found something, having limited time, limited energy, and a lazy brain. It's very easy to just stop there, to find something and stop there. But this is why, like, part of our system should involve maximizing one view. So whenever you maximize one view, you are only looking at this one view. And remember, what we're doing here is ruling out pathology in any of the teeth or in any structures in that scan. We're not addressing the area of interest. When we want to address the area of interest, we will minimize and manipulate our movement handles to only focus on one tooth. But in this case, we want to make sure we look at everything. So when I'm looking at axial, usually on the Carestream software, whenever you maximize a view, you will always see sagittal, coronal on the side of your screen, and you'll have it as reference. So try to see how far down or how far up you're scrolling. So on axial view, I personally start with axial view, then I move to sagittal view, and then after sagittal view, I look at coronal view. So there is no right or wrong when it comes to which view to start with, which view to end with, but I would highly recommend you to create your own pattern. So again, like, if we want a system, we want to first choose which software we're going to use, which buttons to press, which view to look at, and then what order do I want to look at my CBCT scans with. I personally use, again, axial, sagittal, coronal, and we look at the same structures in every one of these views. I would recommend that you look at these 3 views and see which one do you relate to the most. Is it sagittal? Is it coronal? Is it axial? Then start with that. My only condition is the next 10 scans, the next 50 scans you're looking at, to use the exact same pattern, to maximize one view and to scroll, searching, making sure that the structures are normal. So we want to create a pattern. We want to narrow our vision to one view to make sure that we're not jumping from screen to screen. And we want to never stop scrolling. If you think of the cases that we just looked at, most, if not all of them, we were looking at a video. We were not looking at a still image. So this tells us that structures or fractures or resorptions, they behave in 3D. So we want to use 3D to better understand how they're acting. Once you stop scrolling, you will start seeing things. I had a mentor that always used to say, the moment you stop scrolling is the moment you start making mistakes. You will start seeing fractures where there is no fractures, resorptions where there is no resorption, and just because you are diagnosing based off of a still image. And if you're new to cone beam, we want to rely on symmetry. So we want to, especially on axial and coronal view, more or less, we are symmetrical human beings. There always might be minor differences, but we can, on gross anatomy, see if there's anything, any expansion that I see on the right side, but I don't see on the left side, then I should investigate further and see, is this a variation of normal or is this an actual pathology? And if you think about the structures you're looking at, you're really just looking at dental maxillofacial structures that you are comfortable evaluating. So you already look at these structures on 2D, on PANS, on PAs. The difference is you are having a clearer view of teeth and of bone. We're not assuming what we're seeing like we do on PAN. And the last thing we want to do is to divide into smaller sections. So I'm going to go back to show you what I mean. So let's say I maximized one view and I'm only looking at coronal view. One way to narrow down our vision is to start going from outside to inside. So we want to look at the cortical plate, at the medullary bone, at the teeth, and step by step rule out any sign of interruption of the cortex, variation in the medullary bone pattern, changes in PDL, calcification, resorption, lesions, bone loss. So you can step by step go through each one of these structures. And this is kind of what we focus on in our hands-on sessions. And I hope like by the end of the day, after looking at this much scans, it would be easier to apply in your practice, in your office. So looking from outside to inside doesn't mean that that's the way you're always going to do it for the next 100 scans. But in the beginning, when we're trying to create our own system, it is important to spend energy and spend time on each one of these structures. So if we go back and think, how can we incorporate cone beam into routine clinical practice? This way, it's part of our diagnostic protocol and not just the tool we use whenever we don't have any other means that can help us. We really need to think of, when can I use cone beam? How can I customize it? And what should I look for on that CBCT scan? How do I create my own systematic interpretation method? So I think addressing these three parts will make sure that you are like truly effectively using 3D imaging and not just using it as you go. I just have one, well, this should be like a few slides on incidental findings, and then we'll get to the questions. Because I just added this today because I felt we get this question a lot, like how do I recognize what kind of changes in the sinuses I see, especially since it's one of the most common anatomical structures that we do see in small to medium field of view scans. So we want to narrow our scans field of view as small as possible, not just for radiation exposure, but because it does represent the time that you're spending looking at these scans. But the sinuses, you see them almost like every time where you involve the maxilla. So when it comes to the mucosal thickening, we need to recognize like three different scenarios. So the first one is when we have normal mucosal lining. This would be less than 2 millimeters. The second one is where you have localized mucosal thickening and it's apical to a lesion, to PDL space widening, to maybe a tooth that was just extracted. And the third one is we have a generalized mucosal thickening. So each one will give us a different idea. So first one, normal maxillary sinus lining. Here's an example where we see less than 2 millimeter thickness. And this is healthy patient within normal, the sinus floor is intact, teeth are normal, there's no expansion or interruption. So there's nothing for us to act upon. This is a normal sinus. Two is whenever you have mucosal thickening of odontogenic origin. So if you look at this scan, you can see the lesion, you can see the interruption in the sinus floor and localized mucosal thickening. Now, we shouldn't do anything about the sinus because we know the problem is of odontogenic origin. So once you treat the cause, the sinus floor will be intact again. Here's another example of localized mucosal thickening. We have a periapical lesion, we have PDL space widening, and this can be the reason of that mucosal thickening, even if the floor itself is not interrupted. Whereas if you see something similar to these three images, so you see an air fluid level, opacified ethmoid air cells, not just the sinuses, you see air bubbles, and just patchy, non-homogeneous mucosal thickening, then we should think of sinusitis. Technically, sinusitis is a clinical diagnosis, but on CBCT, there are certain findings that guide us into thinking this can be sinusitis. So again, an air fluid level, patchy or non-homogeneous mucosal thickening, and the presence of air bubbles. Now, between acute and chronic sinusitis, we usually, yes, it does depend on how many weeks or if they have recurrent episodes of sinusitis. But on X-ray, on CBCT, we can also see the thickness of the cortical plate. So by the time it's chronic, then that lateral cortex is thickened and it's not within the range of normal. And one very common mistake that I see when it comes to small fields of view scans is that we forget what the normal color of the sinus should look like. So when we see a scan like this patient actually came in feeling that she feels pain every time she bites on her right side. And the clinician's first thought was like, oh, I just did this root canal treatment 6 months ago. Is it fractured? Like, is this why she's feeling pain? But radiographically, there's nothing wrong with the tooth. But when you look at the sinus, you can see it's completely opacified, and we do have an air fluid level. So this is really suggestive that the patient has sinusitis, and that sinusitis can cause referred pain to the roots or teeth that are in an intimate relationship with it. And the last variation of normal we want to think of is the mucus retention pseudocyst. So this is just a collection of mucus within the sinus. There are studies that show that it might pop after a patient sneezes, so we don't have to act upon it. It's just a collection of mucus, could be on the floor, lateral, medial wall of the sinus. So to finalize, I think I'm like, instead of going through this big summary, I'm just going to use this image that really focuses on how cone beam changes our perspective. So if you already use CBCT, you will absolutely relate to this because it changes our thought from like what's happening with this tooth to having a comprehensive general evaluation of the patient's dentition and making sure everything is normal, not just tooth number 11. So, and this would be regardless of your specialty, of your focus, of why you took that specific scan. So thank you so much for hanging on with us this afternoon. I don't over. Let me check. No, we're good on time. Okay, this is my contact information. If you have any question that we didn't get to or we didn't get a chance to answer it. And I think we're ready for questions. Okay. Okay, so I see the first comment that says, is there a vertical fracture? I think you're talking about that case number 1. Yes, there was like a horizontal fractured or perf on the buccal of that premolar. If you were referring to case number 2, then yes, there was an oblique fracture from the occlusal plane. Let me try if I can I go back and show you? With this one, yep, if we play the video, you can see, let's do this. If we play the video, you can see that here is the fracture we're looking at. And in our second case, let me show it to you again. You can see it extend from the occlusal plane and going down, going apical below the alveolar crest. Okay, what size scans do you use for these endo cases? All of these endo cases are 5 centimeters by 5 centimeters of one specific quadrant. So I can see the audience view is, oh, okay, it's 100. So 5 by 5 centimeter CBCT scan. There is one case we looked at, is 5 by 8, where the patient had generalized pain, and wasn't sure where the pain was coming from. Let me show you which one. So this was the only one that was 5 centimeter width by 8 centimeter height. So it involved both upper and lower side of the upper and lower left side. If CBCT scans are so safe and offer better diagnostic capabilities, why do most dental insurance companies not cover or pay for them? Why hasn't the ADA addressed this issue with these companies? So I think this is more, it's more of a political reason rather than just CBCT scans not being safe. Especially when it comes to insurance companies covering them or not, or the ADA addressing it or not. And I know that the ADA has been working on a guide to implement CBCT more in offices. And like the last I've heard about this was a few months ago. But like, again, I think this is more of a like a political issue rather than reason behind cone beams not being safe. Can you send me a chart showing the different effective dose so that I can compare when taking different images? I can tell you I'm going to forget if I'm just looking at that question, but if you email me.
Hey, Lea?
Yes?
Lea? Fran, hey, I already asked their local rep to send it to him.
Okay, thank you, Fran. Thank you. Okay. On an older adult, what's a good KVP in voxel to get better quality imaging? So this would depend on what machine you're using, what voxel size options do you have. I'm going to assume you have a Carestream machine because you're on a Carestream webinar. But I would say 90 kV in 8 MA or 10 MA, or 120 kV with 8 MA, depending if you have the 120 kV options. When it comes to the voxel size, it also depends on why you're taking the scan. So I don't want you to take a high resolution scan on every patient you take, but you do have that option if you need to. When suspecting a pathology in the lower jaw, apical area, mesial buccal number 19, when the tooth is viral, asymptomatic, who would be my best resource for diagnosing? Can I provide CBCT images? Would all OMFS, I think you mean radiologists, not surgeons, be equally qualified? You can contact any radiologist you, if you already know one or closely work with. If the tooth is vital, you see something around tooth number 19 and you're not sure if it's something that should be treated or not, yes, I would recommend you contact a radiologist, share the CBCT scan with them. If you already have someone you work with, then that's good. Could you please say again how we could get that radiation exposure info you mentioned? Unless Fran tells me that they already sent, that your local rep already sent it to you, you can email me and I'll make sure you get it. I need to buy a new computer to play scans from my oral surgeon that treats my patients. to place can, okay. Please give me the specs that I would to get to a quality view. If you have or recommend the best brand to consider. I can tell you which brand I use. I use Lenovo. I've used MSI in the past, but it's really more just about the specs that you have. I think Lenovo is like a robust laptop, and it's the same one that comes with the Carestream machines. I don't have the specs on top of my mind, but if you email me, I can send you what's needed. Can you show how to arrange lines for a specific tooth? Yes, sure, let's do that. Okay, so I'm just going to play this video, and you can see that while arranging the lines, we are changing, let me make this smaller. We're using the lines and changing depending on each color of the movement handle. So when I change the purple line, I'm changing my coronal view. So if I move this, I'm going to see more clearer on my coronal view. As I go further and align on my sagittal view, I know you don't see this here, but there should be a green triangle. So when I change my green line, I'm improving this view. When I change my purple line, I'm changing the view with the purple triangle. So we want to make sure that on axial, these lines are perpendicular to that root. On coronal and on sagittal view, that these lines are parallel to the long axis of the root. There's a lot of videos on YouTube that also show that. If you Google Carestream fill or fill with Carestream, he has a long playlist on how to use the imaging software and how to manipulate your scans efficiently. At the end, will you advise how to take her hands-on course? Very interested. Thank you. So we constantly have hands-on courses all over the US. I think the next one we have is in New Jersey in September. But if you reach out to your local rep, if you don't know your local rep, let me know. I'll put you in contact with them. If you reach out to them, they can give you like where our next hands-on course is. Whoops. Is the 8100 Carestream 8100 sufficient for getting clear imaging? We have a lot of noise on 3D rendering and not such clarity of fruits on different planes. I'd hate to diagnose something without actually seeing what you're talking about. When it comes to the 3D rendering, and you say you have 8100, my guess is you don't have metal artifact reduction. Sometimes if you apply, well, not sometimes, all the time, if you apply metal artifact reduction, it will really improve how the 3D rendering looks like. There's also a lot of settings you can change on your 3D rendering to make it look better. I'm gonna try to look up Phil Carestream YouTube and to show you videos. Like there are videos where you can playlist and where is the CBCT general software. Oops, we're not going to play the video, but that's the video where you want to learn how to adjust your 3D rendering. What's the difference between CS8200 and CS8200 Neo? So the difference between these two machines is, between these two versions, is the acquisition platform. So on the Neo, 8200 Neo, you have a newer acquisition platform. You have also the possibility to take a high resolution scan with an 5 by 8 field of view. So that vertical scan on one side, that's only on the 8200 Neo. Fran, if I'm mistaken, let me know. But I think the difference is the field of view and the acquisition platform you're using.
Yeah, that's correct. And also the taking the high res at a larger size,
Okay, yes.
which
So
is huge if you wanted to do that.
So up to an 10 by 10.
Correct.
Okay. Okay.
And also that one question about the resolution being noisy sometimes.
Mm-hmm.
It was asked earlier, it could be the thickness of the slice, like if they're taking out a super thin slice and they don't have metal artifact reduction, which I don't think they do, that could the metal artifact reduction would help, and just thickening up the slice would make it a little bit, I'll say, more pleasant to the eyes. Not quite as diagnostic, but it looks pretty.
Yeah. Thank you, Fran. There's also one more question. Two more questions I missed. Does the Carestream 8200 CBCT show vertical root fractures? Yes. So the two scans that I showed you, whether it's scan number 1 or scan number 2, they were both taken on the Carestream 8200. So again, like it's a machine and it depends on how you maximize its capabilities. If you really change the resolution every time, these would help to see fractures when you can see them. It doesn't mean you're seeing a fracture every single time. Do you use oblique slicing views as your starting view? How about, I missed a lot of questions. Do you use oblique slicing view as your starting view? How about the other views? When do you use them? Yes, I use the oblique view as my starting. Well, I'm first on curved. I take a pen and then move to oblique or MPR, because this will give me a more generalized evaluation, like to see 3 views together. I would move to other views if we need TMJ evaluation. There's a specific tab for that. If I need to do implant planning or determine relationship between impacted teeth and mandibular canal. So in that case, then I move to curved. But usually it's on NPR. Do you give reports if I send you radiographs and CBCT? Yes, I do. You can reach out to me, the email, and I can share with you instructions on how to go about this. Best screen to rule out vertical fracture without periapical lesion. So I think I would stay on MPR, multiplanar reconstruction, and I would rely more on coronal and sagittal view compared to axial view. There might be more noise, not more noise, but like, yes, more noise on axial view that you might think is a fracture, but is not. So like a vertical fracture, we need to see it from the occlusal surface extending down. I would rely more on coronal and sagittal. What is the name of software you recommended? It was the Carestream imaging software. If you go to carestreamdental.com, you can download the software from there, or if you know your local rep, they can also send it to you. What's a good beginner course for CBCT interpretation? So if you already have a Carestream machine, then I would say like keep in touch to know like when we have hands-on courses. But like a didactic course, I think it would, in the beginning, as a beginner, to learn the software first, to master that, because any like full day CE course I would recommend would not absolutely, but can be more overwhelming, and you leave with too much information, not sure where to start from. So I think in the beginning, learn the basics of your software, and really like the YouTube channel that I just shared helps a lot with that. Okay, do we have any more questions? Do you recommend the J Morita X800 CBCT machine? Actually, like I really like the scans that come from the Carestream, specifically the 9600. The 8200 has a really good image quality too, but if we're talking about endo evaluation and you're comparing these two machines side by side, the 9600 just has a much clearer and more sharp view to it, without adding any thickness to the slices. Metal reduction application is available with any CBCT scan software. I'm not sure what you have, but it's available on the 9600 and the 8200 and the 8100 if you have it. Last question, can you please share the YouTube channel? Yep, let me open it again. So you can just Google Phil Carestream or Phil with Carestream, and that's the one that you'll see. You can go to playlists and you'll see the different playlists for whatever thing you're searching for. The field of views for CS8100 is 8:9. Is it good for general dentist? Yes, I don't think you need it more than 8:9, especially if you're searching for the mandible, the maxilla. You can also move the scan a bit higher if you want to see more of the sinuses. But if you don't care for TMJ on 3D, 8:9 is more than enough. Yes. Okay. I think we got all the questions. And Tammy, I think I'm going to hand it off to you. Thank you.
Can you hear me? It's Tina here. Okay, I'll go ahead and grab that.
Sorry,
That's
Tina.
all right. That is all good. Thank you everyone for attending. Here are some links for you to go back and watch any previous recorded. This is a link for any future courses coming up. Take a screenshot of that. There's going to be a survey at the end. By all means, fill that out. Be careful. There's some things on there like your AGD. If you want me to get that all uploaded, go ahead and put your proper number in there. Make sure it's the right one. If it's not, it's going to get rejected. So I'll get taken care of that. And that is it. I'll send that CE unit out in 2 business days. Everyone have a great evening. Thank you, doctor. Thank you, Fred. And you guys have a great evening.
Thank you.